Warning: this podcast does not introduce any new information outside the Foundation's curriculum. Listener discretion is advised.
Hey there, Central Liners. Welcome to the 4th episode of Real Doctors, Real Friends, the official podcast of Foundations of Medicine. I'm your host, Shireen, along with my partner in medical education, Roshan.
Hi, everyone. We hope you had a wonderful week and enjoyed new sessions and experiences such as DL and Intro to Communications. Thank you for your enthusiasm and continued engagement in Foundations, and congratulations on completing week 4 of the block. We heard a lot of great things about you from our participating instructors this week, so hats off to you, Central Liners. Keep up the excellent work.
Our theme of hypertension this week is one of my favorites because it really highlights the key role of the kidneys and how they play a contribution or make a contribution in our health, and how we can't really separate renal physiology from cardiovascular function and dysfunction for that matter. It also ties into so many aspects of patient care we've been exploring recently, from social determinants of health to interprofessional collaboration.
I've also enjoyed introducing you all to our communications curriculum, which extends throughout your program and helps you develop skills that we use every day in practice. It's truly foundational to building trust and understanding with our patients. Thinking about the importance of patient narratives, let's begin a discussion on social history taking and its significance in clinical practice. Our story of the week featured Charles. We saw how his background as a Nigerian immigrant who requalified as an engineer in Canada, his experiences with racism and disrespect within the medical system, and his personal fears, like the fear of dying alone, deeply impacted his trust and willingness to engage with hypertension treatment.
Yeah, I'm really curious about communication in clinical practice and how feasible it is to meaningfully connect with a patient. In particular, I'm wondering about the 15-minute family medicine visit, because honestly, this sounds luxurious. I've witnessed a family doc only step literally 1 foot in the door, barely glance at my child, and tell me not to worry over their shoulder as they literally walk back out the door. So is the 15-minute visit realistic on the ground?
That's a great observation, Shireen, and I'm sorry you had that experience. Ideally in family medicine, and we're working towards improving that with a better funding model as well as a better support system. We can hopefully provide care in that 15 minutes, and actually what the literature suggests is more like 21 or 22 minutes.
Oh, wow. Okay.
And that's actually the ideal time frame that we need for a typical primary care visit. But it does highlight the tension between the disease model, like the medical diagnosis, hypertension, osteoarthritis, and the illness model, the patient's unique experience of that condition. It certainly seems like if a visit is too abrupt, a patient may not feel acknowledged and their illness experience is lost.
Yeah.
It makes you really wonder how much of a patient's illness experience is tied to not just their symptoms, but their whole life story, their narratives, and their cultural teachings that they carry. Maybe those stories hold more medicine than we often realize. And in Charles's case, his preference for traditional West African carb-heavy foods and his mobility issues made adhering to dietary recommendations really difficult, a factor a quick visit might easily miss.
Yeah. Switching gears a bit, given how common conditions involving the kidney are in day-to-day practice, I'm guessing that explaining kidney function to patients is really challenging because, even at the post-secondary level, this is really challenging. How do we generally approach talking about, say, the kidneys and hypertension to a patient like Charles, who stopped medications due to side effects, and really help them understand what's happening in their body and why medication and diet are important to them? I'm thinking of a scenario where we explain medications like ACE inhibitors to patients. Maybe it's beneficial to help them understand how these drugs truly work, perhaps by describing how they reduce the production of certain hormones to help their heart and kidneys, rather than just reducing blood pressure, which is kind of vague.
Exactly. And we have to simplify complex physiological processes like how the kidneys precisely match sodium and water intake with output to control long-term blood pressure, and how this mechanism is impaired in hypertension. We also need to differentiate between primary hypertension, which often has complex genetic and environmental causes, and secondary hypertension, which has more direct underlying causes, such as a tumor. And when it comes to medications like ACE inhibitors, we can explain how they target the renin renin-angiotensin-aldosterone system, or RAAS, to manage salt and water excretion, which is vital for long-term blood pressure control. Similarly, for diuretics, we can explain their action on the kidneys to promote water and salt loss in the urine to get rid of too much volume and help lower blood pressure. The key is clear, easy to understand language, and oftentimes some visual aids.
Right. Yeah, that would be really, really helpful.
Yeah.
That narrative is crucial. This week, Charles' story also really put a spotlight on the collaborator role in the CanMeds framework. His doctor initially resisted prescribing ramipril based on outdated guidelines for Black patients, citing concerns over poor outcomes with ACE inhibitors. This led to a breakdown in trust, as Charles felt those guidelines weren't written with people like him specifically in mind and trusted his pharmacist, Stan, instead.
The pivot came when the doctor engaged in that interprofessional collaboration with Stan. Stan prompted the doctor to critically reflect and review the original research, which led them to realize that race is primarily a social construct, not a biological one, and that the definition of Black patients in these studies was often ill-defined or self-reported.
Yeah, and the pizza helps with that interprofessional collaboration.
The
right?
pizza definitely helps. Food always helps.
It always helps,
Yes.
exactly. This realization was key to Charles receiving individualized care. It highlights how our guidelines are often based on large population studies, but what if those so-called populations aren't quite as uniform or randomly mixed as we assume, especially when historical events have drastically shifted who's in the pool? This collaboration, understanding Charles' background, his mistrust of the medical system due to past disrespect and racism, and his personal fears, allowed for a co-created treatment plan. From a documentation perspective, how would this kind of collaboration show up in a SOAP note? And I imagine Charles' strong trust in Stan and Stan's advice would be really important to capture.
That's a really great question. In Charles's case, Stan's advice to Charles about ramipril and Charles' strong trust in him would clearly belong in the subjective portion of the SOAP note. It represents the patient's story as well as the interactions that he's had with others to potentially influence that story or have that story come out. Then the doctor's subsequent discussions with Stan regarding Charles's background and treatment options, which influenced the doctor's thinking and action, would generally go into the plan section, P, shaping the next steps. There's obviously some wiggle room, some different ways of approaching it. Sometimes practitioners will put that maybe in the S portion, but it is really a plan based off of a better understanding of the patient's story, their condition, which is hypertension, and now the plan, which is to actually collaborate together on an overall treatment plan. And this demonstrates a clear recognition of other healthcare providers' roles and contributions.
You know, this reminds me of a Seinfeld episode. We always got to bring this in, right?
We do.
So one of the characters, Elaine, gets labeled as a so-called difficult patient.
I wish we could show these clips, but I don't think they're appropriate.
I think there are copyright issues. And
yes.
I mean, yeah, shows like that.
Oh, I've looked through all the clips, and they are still not appropriate to be shown publicly.
Yeah,
the clips
they
are not
didn't
a
age
copyright.
well.
No, not necessarily. No.
Well, Charles had a long history of feeling disrespected and dismissed by the medical system, which certainly made him resistant to his doctor's advice. So how might that perception of a patient being, difficult be influenced by systemic issues or patients' past experiences? Because maybe it's not necessarily that they're difficult, they're advocating for themselves.
Correct. Or they have a lot of trauma that is influencing their response to you at the moment. It's not necessarily an indication of your treatment. And I think with the lack of preparation that we provide our medical students and residents around truly appreciating the systemic factors that influence a patient's response to the healthcare system, the default is just to assume that it's your fault.
Yeah.
Right?
Yeah.
So regardless, it's often a sign of communication breakdown, either with the practitioner and the patient or in other factors, or, and more importantly, deeply rooted distrust stemming from experience of disrespect, dismissal, and racism. And that's not necessarily on you as the individual practitioner. And that's something that Charles had endured. It emphasizes the need to look beneath the surface and appreciate the patient's full context. Speaking of context, Charles's situation also highlights how easily trust can be eroded when assumptions or broad guidelines override a patient's lived experience. When it comes to diagnosing hypertension, we know that simply relying on a single office visit might not be good enough to give us a full picture. Charles had his blood pressure hit 170 at the pharmacy, but his home blood pressure monitoring, or HBPM, provided an average of about 148/92. So what is the value of getting those out-of-office numbers, especially after a patient has diligently tried to follow our advice on diet and exercise? It's crucial for ruling out phenomena like white coat hypertension or even catching masked hypertension.
Yeah, I recently read something curious about the overwhelming load of uncompensated paperwork, which falls to primary care physicians. Some reports suggest this disproportionately impacts female physicians who receive about 25% more messages from staff and patients, leading to greater time spent working through their inboxes and notes. Is there some truth in these observations based on your own experience?
There is definitely truth to that. And it has an impact on Charles's story just in terms of the ability to really engage with a patient when you have to do all of this uncompensated
You already
paperwork.
have like a huge burden.
Yeah.
You have a huge load to deal with.
Yeah.
That doesn't give you a lot of bandwidth
No.
to now sit with a patient and really talk to them.
And so primary care involves a significant amount of paperwork, including charting visits, reviewing lab and imaging results, requesting consults, filling out forms, researching unusual presentations, which I'd say that a lot of our colleagues do in specialty work. But when you're a generalist, especially when you're starting off, there are a lot of things that you're seeing for the first time that you actually haven't been taught.
Right.
Right?
Or the different layers of guidelines
Or
that
the
Dr.
different layers
Salami
of-
mentioned.
Very good
Yeah.
point, right? So advocating for patients, answering pharmacist requests, coordinating home care, it's a massive, almost invisible load. But I will say that provinces, even ours, are making attempts at trying to improve that by changing our compensation model. So we've had a new compensation model be introduced to family doctors in March of this year, which will have tremendous impacts on accounting for this invisible load.
Yeah. So can I ask you, how do you personally manage this load?
So I'm not a great example of this because it's also, and sorry, that's not the greatest way to preface it. I like keeping my inbox clear.
Yeah, I know that.
So that is something that is a double-edged sword. It allows me to stay on top of things, but it also means that I take a little bit more time keeping the inbox clear.
Yeah.
The challenge with that when you start off is that it's an incredibly, I would say, daunting task, and it requires a lot of effort. Having said that, if you reflect
Yeah.
consistently on what are the workflows that you're engaging with, it moves from, if you think about the dichotomous learning, like system 1 versus system 2 thinking, I've been able to move pretty consistently from a system 2 sort of rigorous analytical thinking to more system 1 thinking, where, and reliably so, I've been able to adequately provide patient care and complete a lot of my inbox tasks in a reasonable amount of time.
Yeah.
And the key is about reflecting. So you put in that effort, but then reflect on why that workflow worked in that particular case and remembering it so that the next time it's faster.
Okay.
Yeah.
Is this something that you do on the fly? Like find opportunities over the course of your day, or do you dedicate a chunk of the day to that?
I do it on the fly.
I see you do that
Yes.
sometimes too.
Yes.
So
I'm doing it on the fly.
I guess whatever works. But
Whatever works.
I think it can be complex.
Yes.
Kind of managing those different roles in the moment. And speaking of complexities, this week we also delved into genetics and population health. It's fascinating how understanding the distribution of alleles and variations in genes can help us examine health issues. We learned about the Hardy-Weinberg principle, which provides an idealized model for allele frequencies.
Right. But real populations rarely meet those ideal assumptions when there's a strong preference for individuals to choose mates with similar genetic traits, or if a significant portion of the population is suddenly lost due to catastrophic event, those assumptions are directly violated. That's when we know that some kind of evolutionary force is at work affecting allele frequencies.
And this is particularly relevant for conditions like hypertension, which isn't typically caused by a single gene, but is a classic polygenic disorder. It's influenced by a large number of loci, each with very small effects, alongside a large influence of lifestyle, things like stress that we explored in Charles' case. It's not always as straightforward as calculating the chance of inheriting a recessive condition, like determining the probability of a specific couple having a child with cystic fibrosis based on carrier status.
Correct.
Understanding these population-level genetic variations and how they interact with lifestyle and environmental factors is key to truly individualized medicine. So let's switch gears now for a truly divisive topic because, as our listeners are learning, Roshan and I take things very seriously here on Real Doctors, Real Friends. We're talking about the movie everyone seems to be streaming and dissecting. And I haven't gotten there yet, so I still have to do my homework. K-pop Demon Hunters. We're hearing things like Genu, everyone's favorite demon boy, and even must-eat pre-show ramen.
What's truly intriguing about K-pop Demon Hunters, beyond the fun and great music, is its unexpected phenomenal success. Studios like Sony initially sold off the rights, seemingly underestimating its potential because it was original content with no built-in fan base. They truly underestimated the popularity of K-pop as a genre and the appeal of something new and culturally rich. But tying into themes we highlight in Foundations, its powerful message about being your true self in the face of fitting into a predetermined culture or fate is something we should all reflect on.
That's right, Roshan. This ties in so much with the concept of the hidden curriculum that we discussed this week. In medical education, the hidden curriculum can create an environment where students feel pressured to kind of play the game, so to speak, and prioritize conformity or maybe hide their concerns to appear professional. It's like the entertainment industry being averse to original content because it's a risk.
Absolutely. The movie's success proves that audiences are hungry for new and diverse stories and perspectives, even those deeply other than their own culture. And it's also about recognizing the narratives and unique context that we see in some of those stories, similar to how an elder's creation story isn't just history, but a way to preserve cultural identity and resilience, which are vital protective health factors.
So how does this relate to medicine? Well, just as the entertainment industry can underestimate its audience's curiosity and desire for genuine, diverse content, the medical field, sometimes perhaps implicitly through the hidden curriculum, we might underestimate the value of non-scientific medical knowledge, diverse patient experiences, or the crucial impact of cultural context on health and well-being. This can inadvertently discourage curiosity and vulnerability, not just in our patients, but in our listeners as future healthcare providers. It makes you think about all the factors that impact a patient's care. We've also learned a lot this week about how different drugs interact with receptors. Some, for instance, can activate a receptor, but only to a certain extent, almost like they have a built-in safety switch, preventing an overdose of effect, even if taken in higher quantities. It's all about their efficacy at the receptor level. This contrasts with a full agonist, which can achieve maximum possible activation. How is that for a segue from like non-medical expert to medical expert?
Indeed.
All wrapped in one.
And speaking of efficacy, remember how some cells have more receptors than they actually need to achieve a maximal response? It's like having a reserve that makes the system incredibly efficient, allowing a full effect with a surprisingly small amount of drug. It's fascinating how some medications can have effects that last far, far longer than their actual presence in the bloodstream, almost like they leave a lasting impression by permanently silencing their target, requiring the body to literally build new ones. Hidden curriculum, I wonder.
Yeah.
And when we talk to patients like Ozzy, featured in our weekly review about managing their blood pressure, it's not just about one simple fix, is it? It's about a comprehensive suite of choices, from what they eat to how they move to even how they relax, that collectively makes the biggest difference.
That's a powerful parallel. It connects back to Charles' story, to Indigenous health perspectives, and to our call for curiosity and collaboration. It's about ensuring we truly see and hear our patients in all their complexity without imposing our own assumptions. For Ozzy's case, we saw a striking contrast this week in how different administration routes affect how much drug actually gets to where it needs to be, and how widely it then spreads throughout the body versus staying more concentrated. It's a marvel of the human body how drugs, once they've done their job, are transformed and eliminated. Sometimes the liver is particularly busy doing a two-step dance to prepare a drug for exit via both kidneys and bowel, ensuring it's made more water-friendly for its journey out.
And imagine a critical situation where every second counts. We can't wait 5 cycles or 5 half-lives for a medication to reach its full effect. Sometimes we need a boost, an initial larger dose that immediately fills the body to the level we want, so the treatment starts working right away. Beyond just lowering a number, some medications offer a secondary but equally vital benefit, especially for organs like the heart that might already be struggling. They can help lighten the load on an overloaded muscle, improving its long-term health.
Yeah, understanding the scientific basis and often the physiological basis of how a lot of these medications work is really, really useful, because often, we might have one particular target. So we're targeting a receptor or we're targeting a pathway, but we're actually producing many different effects in the body, which ultimately are beneficial or intended to be beneficial for the subject. It really highlights the depth of understanding needed to tailor treatments, even with shared decision-making. Like for Aisha in our weekly review, inquiring about semaglutide for weight loss, we need to balance potential benefits, risks, costs, and explore all appropriate alternatives, considering the patient's preferences and ensuring autonomy. It's about building trust and effective communication, avoiding, simply labeling someone as difficult when they're reacting to years of systemic issues, and knowing that sometimes what might appear as straightforward high blood pressure can actually be a sign of a rare tumor, or that an accidental exposure to certain chemicals can lead to a very specific set of physiological responses like excessive salivation, lacrimation, urination, and gastrointestinal upset. The more we understand, the better we can care for patients.
Beautifully said. Well, it's been quite a busy week, so it's time for us to unwind a bit and connect with our listeners. We did forget last week's test of friendship to put up in the poll, so we'll be sure to include that about pumpkin spice. But this week's test of friendship on the theme of writing and storytelling: what is your preferred writing tool? Pen, pencil, stylus, keyboard?
Do you want me to go first?
Yeah, of course.
I'm a pen and paper person. So taking my own notes and things like that, using physical paper and a pen, and often, so I prefer like blue ballpoint pen.
Oh,
that's my go-to. I like gel pens and I like colored pens, but like if I was on a desert island and I had to pick like one writing tool, it would be a blue ballpoint pen. Those are my favorite. And actual paper. There was a study in Lancet a long time ago that showed when you actually physically write with a pen or pencil on paper, that sensory feedback to your brain helps to consolidate information and helps you retain information much more effectively than pressing keys on a keyboard or using a stylus on a tablet to write. Yeah, so you don't have that same sensory feedback.
Right.
So when I want to learn something, or when I'm, kind of reasoning through a problem, I always grab pen and paper.
It's interesting. I'd say that I'd say maybe 10, 15 years ago, I would always reach for a pad and paper, pen and paper, because of that. And I totally forgot about that Lancet paper. That's right. And it is, the consolidation of that information is likely to happen much more cleanly because of the sensory input that it's getting.
And you have to slow down.
Because
it takes you longer, like the actual friction of that pen across the paper.
Right.
It forces you to slow down.
That's probably it. I bet you it's that system 2 thinking, right? That laborious analytical thinking that you have to engage in, and all the different signals that are being sent.
Yeah.
I think with how fast my brain is working these days, I think a keyboard is usually going to suffice.
That's your go-to?
but I am moving more now to like even audio and spoken word just because with
okay.
AI,
Yeah,
right?
yeah.
I am still engaging with AI mostly with written like keyboards. But what's interesting is that now writing tools to me have evolved.
Yeah.
Right now with AI, we could even consider them as a writing tool, right? And so I'm kind of on the fence about whether or not audio or AI even is an area that is for me like a preferred writing tool. I still think it's the keyboard for me as the best balance. But I wonder in the next few years if AI, I mean, we talked about citing AI, right?
Yeah.
And how Google so lovingly puts it that, oh no, you don't have to cite AI because Notebook LM or Gemini, they're just like word processors.
Yeah.
Oh yeah, okay. Good job, Google. Way to go.
Yeah.
But no, I think that's something that I think is going to evolve over time. And it'll be interesting to see how our listeners end up using any of these sort of modalities as well as AI in the future.
Yeah, that'll be really interesting.
Yeah.
So, Central Liners, what is your preferred writing tool? Head over to our poll in Assess and let us know your pick.
Well, there it is, Central Liners. Thank you for joining us. Have a great weekend and congratulations on completing week 4 of Foundations. Take care, everyone.